Oh, good afternoon, everyone. Good morning. Good evening to those who are participating from abroad and also in Kenya, East Africa. Feel welcome to today's webinar, the LMSK webinar. My name is George, and taking you through this webinar as your moderator for today. And today we have an exciting topic. Is on mastering good clinical laboratory practices in blood specimen handling for accurate clinical chemistry results. And our presenter today is Mr. Kula Swale Bakari. Mr. Kula is a lecturer at Technical University of Mombasa, School of Medicine and Health Sciences, and is a specialist in clinical chemistry. And without much ado, allow me to welcome Mr. Kula Swale Bakari to start and take it away straight. Mr. Kula, if you can hear me, kindly.
Yes, I can.
Take up the mantle. Thank you,
Mr. George. I hope I'm clear enough, Mr. George.
You are clear enough. You can proceed.
Thank you very much.
Great.
Good afternoon, colleagues. As you've heard, my name is Kula Swale Bakari, clinical chemistry specialist in School of Medicine and Health Science at Technical University of Mombasa. This afternoon, I will take you through discussion about mastering good clinical laboratory practices in blood specimen handling for accurate clinical chemistry results. That means for us to get quality clinical results, then let us practice what I'm going to share with you this afternoon, so that the quality results will result to our aim, which is quality treatment or management for the patient if he's hospitalized, to be discharged earlier, reducing the cost of hospitalization, and doing that way, of course, in the laboratory we'll be happy knowing that we are doing something in the helping of the patients. Our learning objectives as follows: that to understand the do's and don'ts of specimen collection. Here, of course, as the title specified, we'll be talking about blood in specific. To discuss specimen anticoagulants and their uses, to understand the rules of labeling blood specimen collection tubes, and to identify rejection criteria of blood specimen. Allow me to start with the laboratory diagnostic case. We have this case where there is a 56-year-old female who was sent to the laboratory for plasma glucose tests. The laboratory staff collected the specimen in a gray top tube. The tube was properly labeled, stored in the collection rack. When the patient came for the results the following day, she was asked to wait for an hour because the reagents had just been delivered by the supplier. So I've picked this laboratory diagnostic case, something which we encounter sometimes in the laboratory, and in the course of this presentation, I'll tackle this case. So follow me to the end. Introduction. We are talking about blood specimen. So, general, what is a specimen? It's a portion of patient's biological material, which is collected for testing, and the aim is to aid in diagnosis, staging, or monitoring of a disease. So from this definition, it's a portion of patient's biological material. Biological material can be blood, sputum, body fluid, etc. So just a portion from the body, that will be specimen. Then there is also sample. Are they the same? What is sample? What we just defined is specimen. Now, what is sample? Sample is a representative of the specimen. So after getting your specimen from the patient, the specimen will be a representative of what is inside the body of the patient. You don't process the whole specimen in the laboratory. You just take a portion, which should be a representative of that specimen you've collected. You keep the specimen aside for future use. So whatever you pick from the specimen, that's a sample, is a representative of the specimen. And it is this sample where you process. And in clinical chemistry, it is the one which you feed into the analyzer. A reaction with the reagent takes place and the results are produced. So it is the sample which we feed in the analyzer. This sample comes from the specimen which you will store, the specimen store in the laboratory for future use. That's the difference. Now, a proper collection and processing of this specimen is very essential if our target is quality results for quality treatment and management. The type and quality of specimen collected determines the quality of results, as we've said. Now, for blood specimen, phlebotomy is very crucial for us to get that specimen. This phlebotomy is venipuncture. And what do you need for phlebotomy or venipuncture? You need needle with the syringe. This combination is the common old model still in use, where you fix a needle to a syringe. It's okay. Then there is a evacuated tube system, which is the another way of doing it, where you use a needle and specimen holder, tube holder, where you fix the needle in this tube holder, then you puncture the vein. You can also use butterfly needle. When you use butterfly needle, you can also either connect it with the syringe or incorporate with the evacuated tube system. So in clinical chemistry, the specimen we handle include blood, which is the major specimen in clinical chemistry, but also not forgetting the other specimen like urine, CSF, which diagnose disorders of the brain, pleural fluids from the lungs, pericardial from the heart, peritoneal from the stomach, nerval fluid from the joints. But as I said, the major specimen of choice in clinical chemistry is blood. So our topic today will deal with blood specimen. Blood for analysis in clinical chemistry is obtained from either veins, arteries, or capillaries. For the veins, when you require some large amount of blood like 5 cc, you will get from the vein as compared from the capillary, and mostly this for the general tests in the clinical chemistry. For the artery, mostly we use in clinical chemistry, we use it for blood gas analysis tests. And the capillary, it's when you don't need a lot of blood. When you need a drop, go for capillary. When there is a difficulty in getting some blood from the vein, you can go for capillary. For infants and also for point of care testing, that's where capillary is recommended. So to collect blood, you require, of course, the patient, then properly filled laboratory request form. It should be properly filled. This is very essential. The laboratory, other laboratory materials, like the one I've mentioned earlier, the needles, the tubes, and the PPE. Those are the major requirements for phlebotomy. Now, it is recommended that you explain to the patient before taking blood, before anything, when you are handling that laboratory request form, explain to the patient the expectation, what you are about to do. That you greet the patient, then for instance, you can tell the patient that the clinician has sent you here so that we collect blood for some tests. And you can go ahead and prepare the patient by telling the patient that we are going to get the blood from the vein, and this procedure will have small pain, because of course, when you puncture the skin, there will be some minor pain. Just prepare the patient, some minor pain, bearable pain. Then you position the patient either sitting position or supine position, that is a lying, but never standing. The patient should not stand when collecting blood specimen. Then the details required from the patient, which you should have, include the name of the patient, most probably three names. I would recommend 3 names, because when you use 2 names in one locality, 2 names, you can have more than 1 person with similar 2 names. So I would recommend 3 names. Then date of birth is also very important. So for those who will also use 2 names, then couple it with the date of birth, because the 2 names and the date of birth, I don't think you'll get a pair of the same date of birth, the same name. Laboratory ID number, date and collection of the date and time of collection, then the initial of the phlebotomist. Then after identifying the vein, you use a tourniquet, which should not be too tight or staying for too long. Both too tight or staying for long periods will result to prolonged stasis, accumulation of that blood at that local place. And of course, that area will have increased analytes compared to other parts of the blood, which will result to false reports. So avoid that. Then the hands with the IV line, you avoid that particular hand. Take blood from the opposite, the other hand. The IV will interfere with the results, the chemical in that IV. If you are to get from the same line with the IV, then get it below the IV. But first thing, recommended not to use that hand. Then when the IV is removed, for you to go for that hand for blood collection at least 1 to 2 days after removal of the IV. That drug will interfere with your tests. For those patients which have stayed in the hospital for longer periods, for the management of the diseases, we tend to be getting blood oftenly from them. After some time, we go for blood. After some time, we go for the same patient because to monitor the treatment and the progress of the disease. So we tend to get blood oftenly. We puncture these patients. And of course, when there are multiple puncture, can result to bruises or a hematoma. So for those kind of patients, avoid repeated draw from the same site. Then you avoid thrombosed vein. You avoid the hand or a limb which has edema. For the mastectomy patients, that side which was done mastectomy, this is a removal of surgical removal of breasts. That side where mastectomy was done, you avoid the hand of that side. Don't put tourniquet on that hand. In fact, avoid that particular side. Use the opposite side. You avoid drawing blood from the areas where there are shunts, pipes. These are pipes which are used to drain some body fluids out of the body. So where there are shunts, avoid that area. Where there are casts, avoid that area. Cast example of the cast could be like the POP, plaster of Paris, something like that. So you've gotten your blood specimen. I want to introduce two anticoagulants, which we normally use for the specimen. But the best practice actually is you test the fresh specimen. That is the best practice for the quality results. Test fresh specimen. When there will be a delay, which in most cases when you have a lot of work, a delay is there. Then if a delay cannot be avoided, then that's when we use anticoagulants, which will help the specimen stay for some time also. So when you add anticoagulant into your specimen in the tube, make sure you use a appropriate proportion of anticoagulant with the blood. You mix gentle, avoid vigorous mixing. When you mix this blood with anticoagulant, then after sometimes about maybe 20, 30 minutes when you centrifuge, whatever you will collect is plasma. Plasma. Serum you collect when you get it when you collect blood in a plain tube or a tube which has a clotting activator or a gel separator. That is serum. That's the difference. Now, as you are drawing the blood, if maybe you have multiple tubes for multiple tests going to different sections, specimen going to is the same patient, but specimen going to hematology, specimen going to bacteriology, clinical chemistry, and some other places. That is multiple draw. Then the Clinical Laboratory Standards Institute recommend that you follow the following order, strictly that order, that you start filling the blood culture tube. Next should be citrate tube, then followed with the tube which is plain or has clot activator. They work almost similar. Then you follow the tube which has a gel separator. Next should be heparin tube, then followed with the ADTA tube, and finally fluoride tube. In that flow, for instance, the blood culture should be fast because of the obvious reason that it should be completely sterile. That's why we start with blood culture. Then the citrate is next because, again, this one you really strictly require the required proportion, which is 9. The ratio is 9:1. This is for coagulation screen, which really requires a strict ratio of 9:1. Less than that, slightly less, more than that, you interfere with coagulation screening. Then next is a plain tube for serum or a tube with the clot activator. Then followed with the heparin. There is heparin and ADTA. If you interchange ADTA, then heparin, you can transfer some ADTA into the next tube, which will be heparin. By doing that, ADTA has some potassium and sodium. Those are electrolytes, will interfere with the plasma in heparin if you are to analyze for electrolytes. That's why you start with the heparin, then you go to ADTA. And you can ask, so won't ADTA interfere with the fluoride? The fluoride is for estimation of glucose. We are measuring glucose here. So transferring of electrolytes will not interfere. That's why it is organized in that order. And those are the tubes. Those are the tubes. The first one on your left, blood culture in that order. Blood culture tubes followed by citrate. Then plain, the red one, or the clot activator, or the gel at the same level. Then heparin tube, ADTA, glycolytic inhibitor, just like I've described earlier. So just a brief of what color code and the additive. We started with the red. Anyway, let me go just the way it is. Gray color top. The additive found there is a sodium oxalate or potassium oxalate. That is an anticoagulant. But it also has sodium fluoride or sodium iodoacetate. These ones act as a glycolytic inhibitor. They interfere with an enzyme found in glycolysis called enolase enzyme. They inactivate that enzyme, stops glycolysis, where it's a process where glucose is being used to generate energy. So when you stop glycolysis, then you stop usage of glucose by the cell. You maintain the concentration of that glucose. Then the yellow tube is sterile. Green is the heparin, and I have to also note here that the anticoagulant of choice in clinical chemistry is heparin. That is the anticoagulant of choice, which provide for general most of the chemistry. It is the green top tube. It has sodium, heparin, lithium, or ammonia. The red top, this one has got nothing for serum. Blue is for the citrate coagulation. Lavender, ADTA, mostly for hematological parameters. So selection and use of anticoagulants. Make sure that the anticoagulant you use does not remove what you are analyzing, does not remove from the specimen what you're analyzing, and it does not add into the specimen what you're analyzing. For instance, if you're doing electrolytes, potassium and sodium, don't use anticoagulant which has sodium and potassium like ADTA. It will add into your specimen potassium and sodium. And if you know the mode of action of these particular anticoagulants, they have different mode of actions, then the ADTA again, the way it works, it chelates calcium, removes calcium from the specimen. So again, if we are saying the anticoagulant should not remove, so if you are doing calcium analysis, then don't use the ADTA will remove the calcium. You get lower values, while the same ADTA will give you higher values for the electrolytes. That's an example. That's why we recommend the use of heparin. Then use neither excess nor less amount of anticoagulant. When you use less amounts, your specimen will clot, interfering with your results. When you use excess anticoagulant will lyse the red blood cells. It should not be an enzyme inhibitor if that enzyme is being analyzed. Like I've mentioned about the gray top tube, where the fluoride, sodium fluoride, inactivate enolase enzyme. So that one we are using it because we are analyzing for plasma glucose. But of course, if we were analyzing that particular enzyme, we can not use that one. So any anticoagulant which inhibits enzyme which you are analyzing, don't use it. So after collection of your blood, you have to label the specimen. So the rule is, when it comes to labeling, follow institution policy, the accrediting agency requirements kindly. Because when they come for accreditation, they give you their requirements. Follow that one so that you pass accreditation. But what is possible? What is there is that even those institutions have as minimum what follows. One, always label after blood is drawn. Do labeling after the blood is drawn. Not before. There's some people label even before they've drawn the blood. What if you miss the vein? What if eventually the blood is not drawn? You've wasted that Vacutainer. You've already labeled. You cannot cancel and use it for another person. No. That's why we say always label after blood is drawn. Always done when the patient is still there or at the bedside. Do not label before. Do not label after you've left the patient. Maybe there are some other details you'd like to confirm. Kindly you label when the patient is still there. You again label the cup, not the lid. Because if you label the lid and maybe there's a mix-up of lids on the table, you may not know which one is for what. So you label the cup or the tube, not the lid. Then you separate the cells from the blood fluid immediately. Get your serum or plasma. Apply appropriate storage condition, and all specimen to be regarded potential hazardous. Then some of the analytes are concentrated in the cell, others in the plasma, and some are just equal all over. I think should also have that knowledge. So that and this is the reason why we say centrifuge immediately to separate cells from the plasma or serum. We like potassium phosphates, AST and LDH, lactate dehydrogenase, aspartate transferase. Those ones concentrate more. The concentration is more in the cells, intracellularly more. You also find them in the blood fluid, but more concentration is in the cells. Sodium and the chloride, more concentration is in the plasma. While concentration about the which are equal creatinine, glucose, urea, and urate. That is the reason why when you are doing electrolytes, you have to separate immediately so that you are left with the plasma. As you can see, potassium is more in the cells than in the plasma. What we are measuring normally is what is in the plasma, and we have the reference range we have is what is in the plasma. If you let the blood to stand for quite a longer period, there is a tendency of plasma shifting from intracellular to the plasma, increasing the levels of plasma potassium. So, changes in specimen on standing. As I've said, there is if it stands for a longer period before separating cells, there's a diffusion of potassium into the extracellular space. There's also diffusion of some enzyme into extracellular space. If we say enzymes are intracellular, that is their location, then they are meant to work inside the cell. Meaning, if they get to extracellular, their activities are reduced, because that is not the space where they are supposed to be working. Then there is a tendency of diffusion of carbon dioxide off the surface of the blood specimen, if the specimen is left to stand for quite a long time. This relies, you place this in B blood gas analysis tests. Then again, glucose concentration decreases 10% per hour, 10% per hour, if it stays for longer period. Within 1 hour, you should be testing your analytes. There's a reduction or loss in activity of certain enzyme, as I've said. There's decomposition of bilirubin when it is exposed to light. Of course, we have light in our working space. It is part of the working space. We need light. So it gets decomposed with the time, so you should not let the specimen stand for quite a long time. Then a decrease in volume by evaporation. So rejection criteria. Never accept unlabeled specimen. Never accept mislabeled specimen. But there is an exception to that. Majority of the specimen never accepts if it is unlabeled or mislabeled. But there are some specimens which are difficult to collect, like CSF. Some specimens which require immediate processing. It's emergency case, again, like meningitis, CSF, bone marrow. For those specimens, this particular point is exceptional, but the rest don't accept unlabeled, mislabeled. The reason is as follows. Okay, for the mislabeled, when you are labeling, as we said, use at least 2 identifiers. That is, we said the name and the date of birth. At least 2 identifiers, name and date of birth, to minimize errors. Then quantity not sufficient. When the quantity collected is not sufficient for the multiple tests requested in the form, that meet the rejection criteria. When the tube is has been underfilled, that meets the criteria, because underfilled tube will have a wrong blood to anticoagulant ratio. This will interfere with the results, as I said earlier, hemolysis or reclination. Anticoagulant specimen clotted. It is anticoagulant specimen but has clotted. You reject. You have used the wrong tube for certain tests, like I've explained about ADTA and electrolytes. You reject. Outdated suppliers. What has expired? Like, for instance, for the tubes, expired. These tubes normally work on vacuum. They withdraw blood into the tubes based on the vacuum, creation of the vacuum. The blood is aspirated inside. So when they expire, the vacuum is also lost. If it is reduced, then that particular or lost, that particular tube will be underfilled. It will not be filled to the required level because the vacuum is lost. So underfilled will result to quantity not sufficient, and maybe you are supposed to do multiple tests. Then timed specimen drawn at wrong time. If it is drawn at the wrong time, you reject. Like in endocrinology, some hormones are time specific. You analyze them in the morning, at noon, and also TDM is a therapeutic drug monitoring. You require timed specimen. Then fluid, when there's fluid contamination from the tissue or the IV into the blood, you reject, because now the composition of the blood would have been altered. When there's lipemia, lipemic specimen, you reject. The lipemic specimen is a cloudish, milkish. You reject because it interferes so much with the clinical chemistry analysis. That's why in some tests we request the patient to fast. Fasting ideally is to burn the fats, reduce the fats, so that we get the recommended results. So if patient has not fasted adequately, then there are tendencies of having lipemia, lipemic samples. Or if you've drawn blood immediately after the patient has taken meal, it will be lipemic. So when when you have a lipemic specimen, you go ahead and do analysis. Then of course you will discover that the fats are high, triglycerides are elevated. Now, the question will be, is that a true picture? That is it true that the triglycerides are elevated, so the patient has high triglycerides, fatty, of high lipoprotein, or it's because the patient did not fast adequately as required? Because when we're doing triglycerides, you have to fast. When we're doing fasting plasma glucose, you have to fast. If you don't fast, those values will be high. If you do it inadequately, those values will be high. Now, we want to know, is that high value indicative of a disease, or it's because of poor fasting? That's why you should not analyze a lipemic specimen. Then lipemic specimen results to pseudonatremia. Lipemic specimen can result to low levels of sodium. Low levels of sodium, but these low level sodiums are just found in the specimen. It is not a true picture in the body. That's why we call it pseudonatremia, because there are some analyzers, they analyze the sodium based on the body fluid. Now, in this case, the body fluid has been covered by a lot of fat, so it interferes with the ratio. That's why you get pseudonatremia, so you avoid that. Icteric specimen, that's a lot of bilirubin. You are reject. Then hemolyzed specimen, you also reject, because it gives inaccurate results, because This hemolyzed blood is not the picture in the body. Is there hemolysis in the body? Then you'll have also to take another specimen to rule out that. Then packaging and transport of what you have collected and properly labeled. Packaging is in a 3-tier system. It is done using 3 containers. The first container is the one which holds the specimen. It holds the specimen. Then you insert it into a second larger container, which should be leak-proof. Then finally, into the third container, which will be the transporting container. All these 3 containers have to be labeled, and they should be leak-proof, puncture-resistant, prevented from leakage, breakage. And as I said, label them appropriately. Keep upright, secure the containers, cushion the specimen, and you maintain the required temperature. Safety and tracking. So after the proper labeling, you verify this, of course, labeling to prevent mix-up. You handle with care to avoid overloading. Avoid overloading transport carriers, or you can use the padded carriers if necessary. You track chain of custody. Get a record of who is handling the specimen from the beginning to the end as it is dispatched. Follow special handling procedure. If there are some contagious specimen, to follow the required, recommended specific packaging procedures. Transportation can be within the region from one hospital to another, or from one country to another, that is shipping. In the laboratory, when you receive this packaging, make sure you remove the stoppers carefully to prevent aerosol, because they've been on transit, collision. This collision of the specimen as being transported can form aerosols. So they are dangerous. Discard waste properly in a biohazard container. Laboratory diagnostic case. A 34-year-old male patient who has a history of vomiting, stomach pain, and is jaundiced, was taken ill to hospital and sent for laboratory tests. His blood specimen was collected and tests performed. The following are the results, which were sent to the doctor. Total cholesterol, 4.8, triglycerides, 0.8, low density lipoprotein cholesterol, 2.2, high density, 3.1. Those are the results sent to the doctor. But the doctor had question marks. When you look at the results, these are lipid profile parameters. Lipid profile parameters. But can you check at the history of the patient? The history of the patient is vomiting, stomach pain, and jaundice. The patient has jaundice. So with the jaundice, you suspect, or you suspect the liver, no any other organ. And for the liver, you expect to do liver function tests. But now Now we should have to do liver function tests. So if the liver has a problem, that's why the patient has jaundice. Yes, it correlates with the stomach pain, and sometimes they do vomit. Instead of liver function tests, the report which goes to the doctor is a lipid profile. There is a problem here. Most probably, these are not results of these patients. There's a mix-up. So when we don't follow the proper labeling, label at when the patient is still there at the bedside, after blood is collected, you can mix the specimen. Details, as I said, in one locality, when you use 2 names only, you can have many people with those 2 names in that region. So if you combine, you either use 3 names or combine with date of birth, the better. So this is a case where there is a mix-up of results. Most probably the results of this patient was supposed to be liver function tests. Another laboratory diagnostic case is the one which I started with. I'll take it again so that I also solve it. Year-old female was sent to the laboratory for plasma glucose tests. The laboratory staff collected the specimen in gray top tube. This tube for preservation of glucose, because you are doing plasma glucose tests. Labeling was done properly and then stored in the collection rack. The patients came the following day after 24 hours. Then after asking for the results, she was asked to wait for an hour. Why? The reagent had just been delivered. So the laboratory had no reagents for plasma glucose at the time of collection. So meaning the blood stayed since the time of collection until that particular time when the results had just, the reagents had just been supplied. The random blood glucose was 2.2. This is even below the fasting. It's even lower below the fasting blood plasma glucose. So this case, we can argue it out that the glucose concentration in the plasma, because the specimen stayed for more than 24 hours, maybe it was in the rack only, not taken to the refrigerator. But even if it was taken to the refrigerator, still staying for 24 hours, as we saw in our presentation, glucose reduces 10% at the rate of 10% per hour. So this was not recommended, and that could be one of the reasons why we ended up getting low levels, like even below the fasting blood glucose. Conclusion: get it right to reduce the weight. You get it right at the starting point to reduce the weight, because if you get it wrong, mislabeling, not enough specimen, etc., hemolyzed specimen, etc., the patient will be forced to wait, because you'll have to collect another specimen, torture the patient. Now, of course, you will place the specimen aside and wait until the patient comes up with the results. Then you explain, you take another one. That's delaying. So get it straight to reduce the weight. A quality collected specimen. A quality collected specimen will give quality laboratory results. If you follow what we've discussed this afternoon, you will be collecting quality specimen, which will give you quality laboratory results. And what do quality laboratory results do? They provide accurate and a precise treatment to the patient or management of the patient. That is our goal. Thank you very much. Thank you. Thank you. Thank you. Over to you.
Thank you very much, Mr. Kula. It's quite remarkable. It's a wonderful presentation. This is one of the core areas.
Sorry. I can't get you properly, Mr. George. Sorry.
And is well presented.
If you can hear me properly, Mr. George, from my end, Mr. George, you are breaking. If you can hear me properly, from my end, Mr. George.
Yes, I can hear you. I don't know. Can you hear me right now?
Yes, now at least, Mr. George.
Good. Thank you very much. And maybe there have been some hitches. It is understandable. I was in the process of appreciating your presentation. It's a wonderful one. And I hope that the participants, the medical laboratory practitioners, have really learned a lot. The case studies and all the illustrations that we've used are quite relatable with what we encounter in the medical laboratory setup. So I can see quite a number appreciating your presentation, and I think I'll just come to that later. Let's shift the focus to the questions that are there. And if there's any question that any of us might have, kindly use the Q&A section so that I can actually access them more efficiently. Benson Lusenaka is asking, what happens where samples are taken by nurses from the ward? Yeah, now that the medical lab practitioners have been well equipped with this knowledge, now what happens when samples are taken by nurses from the ward? So I think Benson is assuming that the nurses have not been well equipped with this, with the requirements. So I think, Mr. Kula, you can respond to that.
Yes. Thank you, Mr. George. Yeah, it's true. It does happen in the wards. Nurses do collect specimen, even clinicians do collect specimen. Then they bring it to you for processing. And unfortunately, when the results are wrong, blame fall onto you in the laboratory. So my advice would be that the aim here, the goal is to help the patients so that they get results at the right time, no delay. So we have to handle this issue politely with the wisdom. Let us provide CMEs to all those who are included in the collection of specimen, like the nurses, the clinical officers, or any who is not a laboratory personnel, who is collecting specimen out of the laboratory. let us have a tendency of holding some CMAs on this and many more concerning the workings of the laboratory. That's what I would suggest.
Thank you very much for that. It's, we have Wilfred Moriasi. I'll just read it the way it is. I have an experience with a client who fasted more than 8 hours, but still the sample was milky or cloudy. Should I reject such a sample or I proceed with analysis? Over to you.
Okay, thank you very much. When you ask the patient to fast for lipid profile, then you get that the specimen is milky. There's a procedure they do which actually, if given opportunity, I can present that procedure, title in future if I get opportunity about handling the lipemic specimen. But in breve, you centrifuge the lipemic specimen. Then when you get the plasma, there are some reagents for clearing the lipids, reducing the lipids. Then you mix with the it's called the lipemic reagents, so that you reduce the lipids. Then you analyze. But after analysis, remember, this is not the exactly specimen. You've done some dilution to remove the lipid. So when you get the results, multiply with the dilution factor to get your results. But I would assure you, if the patient has fasted adequately and the specimen are lipemic, then you'll get high triglyceride results, which is the really condition of the patient. The only thing why you should centrifuge to reduce the lipid is sometimes lipid interfere also with the analyzer. Thank you.
Thank you very much. It's quite elaborate. I hope that Wilfred has taken notes on that. Next question, Mabel Ndoku is asking, there are samples which are very painful to withdraw from patients like CSF or bone marrow aspirate. Is it possible to reject?
Okay, thank you. I have that one has been captured in my presentation. There's a slide which I said that we reject unlabeled, mislabeled specimen, but there is an exceptional. Exceptional is what she has said, that the specimen which is difficult to collect, like CSF at bone marrow, I mentioned that. Those ones, there is exceptional. In fact, CSF is labeled as an emergency test. So there's expression for that. And why there's exception also, in most cases, those specimens are very few, can get one or two, which will also easy the mix-up. Thank you.
Thank you very much. Mabel, I hope that you've got that. Very important. Martin Mutunga. In case you have both hands of the patients under infusion fluids and you're supposed to collect blood, which is the preferred site for that matter? Yeah, you talked about hand that has fluids, ignore it and go to the other one. Now, how about when both hands?
Okay. I also said that if it's a mandatory that you get from the hand, which first of all avoid, use the opposite. But if it's a mandatory, maybe both of them like that, you can take below the IV, But I would also recommend that you go for the artery, and that you should incorporate the specialty, the doctor, so that they get the arterial blood. Thank you.
Thank you very much. That's wonderful response to the point. Now, there's a question here about, I'll give you two questions at once. For the vacutainers, when you are collecting blood samples, there's one asking, do you recommend opening the vacutainer top when putting the samples? And again, for the samples again, for how long are they supposed to be centrifuged when we're doing separation? Over to you.
Okay. Opening the tube. Actually, it is not recommended to open the tube simply because this tube, the way they are manufactured, they have vacuum. We call them vacutainer. They have vacuum inside there, and that's the essence of that vacuum, is to help with the drawing, pulling blood inside the tube. That is the essence of the vacuum inside there, and that's why it is called a vacutainer. That's vacuum there. So some people do it, but it is not recommended. What you're supposed to do is you use the evacuated system, whereby there is you use the holder, tube holder, and a needle which has a screw. You screw it. That's closing system. Then you take your blood. That should be the best way of using the vacutainer. So I would say it is not recommended because you'll be losing the vacuum, which is essential in withdrawing. Then if you over centrifuge, you lyse the cells, causing hemolysis. So centrifuge 3,000 revolution per minute for 5 minutes or less, 3 to 5 minutes. The lower should be 3 minutes. If you go high, 5 minutes, not longer with the duration, and not high speed. 3,000 revolution per minute for 3 or maximum 5 minutes, because a higher speed and longer will lyse the cells. Thank you.
Great, that's wonderful. Thank you very much for that. More questions are still streaming in. There's this simple one. Okay, good. Anonymous attendee is asking, when do you label a urine collection container? Is it after the urine collection or before? You talked about it, but you can just stress about the same.
Okay. You normally, labeling is done when the patient is still there, has not left, or if it is in the wards, we say you label at the bedside. So, for instance, with the urine container or other container, if the sample is not achieved, You will agree with me this particular container is a waste. Of course, it cannot be, you've already labeled it. You cannot use it to another person. Again, for the urine, for the blood, it is you who is taking it there. You will be sure that this is for this patient. For the urine, you've sent the patient to the toilet. Maybe it's more than one patient for urine sample. They are there waiting for one another at the toilet or wherever. You never know. They can interchange if they don't know how to read. We have illiterate patients. They can interchange the specimen. So let them bring the specimen, label it there when the specimen is inside the container. Thank you.
Thank you very much. We are moving on well. Let me not ignore this. Evans is asking, you talked about CSF, yes, and you elaborated quite a lot how special they are, but there's still a question here. Handling insufficient CSF sample. If you can just have a statement to just stress about this, Mr. Kula. How do we handle insufficient CSF samples?
Okay, with that one, it will depend how insufficient, because if it is insufficient in a way that it's just a drop, or there's no drop, it's just it is on the side, stuck on the side, then that one is extremely insufficient. You cannot get anything. But if there is a small amount in clinical chemistry, kindly do what you can. Like in clinical chemistry with the CSF, mostly we do the sugars, glucose, and protein. That is mostly what we do in the clinical chemistry. The rest is done in some other sections, bacteriology and others. So if you can do if you can do some few tests, the better. But again, you can dilute the specimen, that specimen. But remember, when you are diluting it, you are not using the exact specimen which came from the body, because of diluted, meaning at the end of it, you have to multiply with the dilution factor to help you get to the closer, accurate figures. Thank you.
Great, that's good. Thank you very much for that. I hope Evans Ocheng, you are now sorted. Do not discard the sample. Just do as you've been advised. And there's one more here by Calvin's. Calvin's is asking about a test. For example, performing oral glucose tolerance tests, and the results does not tally with the control values. I mean, it's like the control, the controls are not syncing with the values that are set for them. And also the LJ, the Levy-Jennings chart is not also properly aligning the way it should. So for this case, where the controls are out of phase, how can this be handled?
Okay.
Yes.
The way I understand it, or the way I know, is that you handle the controls which is tagged to the Levy-Jennings chart before running your tests. The order is run your control, let your control pass. Then you run your tests. You don't run the tests, then the control, you do the control and then you see they are off. So run the control, that is the proper way, the way I understand it. Run the control, let the control pass before you do any test, because if the control have not passed, then all what will be doing thereafter for the patient, those are wrong results, inaccurate results. That's how I will frame it. Thank you.
Great. Thank you very much. Is actually that. And Calvin's, I hope you've taken keen note of that. You run the controls first, let them, they need to pass. If not, troubleshoot until they pass, then you run the test. So just as it has been explained, that's very, very important. That's why I've also stressed on it. Thank you very much for that, Mr. Kula. Now, Patrick Ahemba is asking a question. Let me just read it all through because it seems to be long. It starts by saying, why don't you draw blood on the mastectomy side when the patient is going to get IV chemotherapy? And is continuing to say, we were told to remove samples on the hand on the affected side, and the patient receives chemotherapy on the other hand to avoid extravasation. I don't know, Mr. Kula, can you respond to this?
Yes,
Or can I read it once again?
No, it's okay. It's okay. I think
Okay,
I've
good.
gotten it that why we should not draw samples from the mastectomy side.
Yes.
Okay. The reason is because when they do surgical mastectomy, we have to remember here they remove the lymph nodes. They remove the lymph nodes of that particular area. What is the work of the lymph nodes? That is immunology. So that particular area's lymph nodes are removed. For your information, just in brief, lymph nodes protect you. That is immunology, give protection to you. All microorganisms are trapped there and destroyed, eliminated. So if that local area lymph nodes are removed, because that's what happens, then in case of introduction of infection, you are posing danger to this person. Another thing, the tourniquets will interfere with the flow of the lymphatic fluids. So don't use tourniquet on that side. Don't get specimen from that side, because in case of infection, that particular local area whereby the microorganism have to be trapped immediately before they spread, it will be a challenge. Thank you.
Great, that's wonderful. Yeah, on the chat, Ellen Akwana is raising something here, and I think you had talked about it. Is a statement, if you're using a syringe and a needle to withdraw blood, does it mean that you use the needle to pierce through the vacutainer? I think the answer is yes, Mr. Kula.
If you're using a syringe,
yes, to draw
yes,
blood.
Yes, actually, yeah, that's what we've been doing. That's what we've been doing. You use a needle syringe, then you don't transfer with the needle. You remove the needle, incinerate, possible, then you transfer it to the vacutainer. But ideally, maybe that's what we didn't know before. But with the introduction of the closed system, as I've explained, ideally these vacutainers have vacuum inside. They put vacuum inside there. That's how they are manufactured, so that when you use the closing system, whereby you just press the tube into this holder, then the blood will just enter on its aim under vacuum. That is the essence of these vacutainers. But long before, we used to remove the top and do like that, which was actually not recommended. So I'm just sharing information on how it is recommended, but people do it the way she said. So I think I'll leave it like that. The recommended way is, if possible, use the closing system. But if you don't have, then of course work should continue, but it is not the proper way of doing it. Thank you.
You're welcome. Thank you too for that. I'm trying not to ignore any question that is lingering on our side here. Oh, Calvin seems to be more interested in CSF samples. I think you can also just give a shot to this. And Calvin is asking, can CSF mixed with blood and pus be suitable for clinical chemistry tests? CSF that has blood and pus in it, can that sample be suitable for clinical chemistry tests?
Okay. It is not suitable for clinical chemistry tests simply because as I said, the common tests we do for CSF in the clinical chemistry is mostly the protein and the glucose, which are indicative of infection. Remember, blood also has protein and glucose. I should also note here that the values, the reference range of glucose in a CSF is different from the reference range of that one in a blood. It is higher, the one in blood compared to the one in CSF. The protein the same. They have different ranges because in the CSF, the amount is very little compared to the blood where it is more concentrated. These two have different ranges. So if blood is a contaminated, CSF is contaminated with the blood, means you have introduced more glucose, more protein. You'll get erroneous results. Thank you.
Great. More questions are streaming, still streaming on our hand here, and time is on the other side. Time is not on our side, but I really try to at least ensure that most of them are attended to. Benson Losenaka, there's talking about blood sample that's obtained from vein or artery. Now, the question is it necessary to indicate to the clinician that the sample, the blood sample, was taken from the vein or the artery?
Oh, thank you very much. Yes, you have to indicate that this specimen is from the vein or artery. For instance, see, when we do blood gas analysis, the recommended, mostly used specimen is artery. But when you miss artery, you can use vein. Then here, because vein is not common, you indicate that you've used vein, so they'll know. They'll still process, because this is in a blood gas analysis, these are emergency cases. They'll still process the vein, but they will use reference ranges of all those parameters of blood gas as far as venous blood is concerned. They will not use the artery reference ranges. As we know, oxygen in artery and oxygen in vein differ. Carbon dioxide in artery and carbon dioxide in vein differ. Those are some of the parameters of blood gas analysis and others, the renal function tests. So it's good even for other specimens, not only blood gas analysis, even in other specimens. There are some other parameters in clinical chemistry which have different values when in plasma and when in a vein and when in artery. So it is recommended to indicate. Thank you.
Great, that's wonderful. Quite a lot of the medical laboratory practitioners are appreciating your presentation. And I can see Boaz Odongo is saying good presentation. Quite a number, Faith Chepchirchir, wonderful presentation. That is good. Sakina Omar, good presentation. And you can also see the thumbs up over there. And also to that, there is David Ciele. David Ciele, I think you must have interacted. David Ciele is saying, thanks for the great presentation, Mr. Sole Bakari, a former classmate in college. I think you must have been classmates with David Ciele. He has actually appreciated your work.
Thank you.
That's good. Just to wrap it up, there are two questions here. I'd just like you to just attend to them briefly. You talked about them and you elaborated, but also you can just remind them who have just asked the questions. They might have joined maybe late. Alice Kinyo is asking, are there any marked differences in results obtained from plasma or serum? So that's after you've centrifuged, you've separated, and then one person gets plasma, the other person gets serum. Now you do same test. Will there be some differences? Another question, you will just answer them at a go. There's one who asked about blood sugar, random blood sugar. So this is also very key. Is it advisable to use EDTA, anticoagulated blood, in random blood sugar test? So can you respond to them? This Janet Chepkorir who asked that.
Okay.
So over to you.
Thank you very much.
All right.
Sample as plasma or serum. In most of the clinical chemistry analytes, there is a slight minimal variation in clinical chemistry, minimal variation. But in some other areas, remember how you form plasma and how you form serum. In serum, all coagulation factors are missing. They've been used up in the formation of the clot, all of them. These are some proteins, coagulation factors. They are missed, some of them are proteins. They are missed up. So that's one of the difference between serum and the plasma. And again, when you use anticoagulants, it depends which anticoagulant. If you use the one which removes some analytes, like calcium is bounded by some anticoagulants, ADTA. Chelate removes calcium. Make sure that particular plasma, you don't use it for calcium analysis. But if you avoid that, I'll say most of the clinical chemistry analytes between plasma and serum, there is a slight difference. not a bigger margin, but use what is recommended. Like in clinical chemistry, I would suggest heparin, the green top tube. That is recommended anticoagulant of choice. When you get to random blood sugar with ADTA, first of all, I would just sharing it is just sharing idea. I would prefer calling it glucose, not sugar, because sugar entails glucose, entails lactose, entails sucrose, entails many of those ones, hexose. But I believe we are talking about diabetes mellitus. For diabetic mellitus, it is only glucose which is a responsible there, as we do test for glucose. So I would prefer calling it plasma glucose, not sugar. And you should not use ADTA because you have to remember glucose in blood is being used up continuously. Even after you've removed this blood from the body, on standing outside here, the cells have to survive. The cells will be using glucose. So we do prevent this usage of glucose. And to remind you, that is the process is glycolysis. We have to arrest glycolysis by using anticoagulant of choice, which is a sodium fluoride. That one inactivate an enzyme in glycolysis called enolase and arrest that particular process and maintain the glucose in blood. Eventually, you'll get accurate results. Thank you very much.
Wow, what a wonderful explanation. Thank you very much, Mr. Kula. It's been an exciting and encouraging presentation. Thank you very much for that. I can see our time is gone. And at this point, we are coming to a close of this session. But before we conclude, I would really like to call upon our presenter, Mr. Kula, just to give us a parting shot. Maybe a statement as we come to a close of this session, something that maybe you can use to encourage us, something that maybe is striking in the presentation, or something about clinical chemistry that maybe you'd like to tell us as a parting shot as we move towards the end of this presentation. So, Mr. Kula, if you can just take like 30 seconds or 1 minute,
Okay.
your parting shot, we'll
Thank
appreciate it.
Thank you
Over to
very
you,
much.
Mr. Kula.
Thank you very much. Actually, I would like to be grateful to LMSK. Actually, LMSK is doing a wonderful job to help us provide information rich to many laboratory personnel across the country so that we can share whatever we have with them so that we can improve our field of the laboratory medicine. It's only us, nobody else, who know our house and know how we can improve it. So a wonderful job by LMSK to be conducting these webinars. Thumb up. Again, what I'd like to say also to finish with is I'm willing anytime, given opportunity, I can still join hands with LMSK to provide more webinars. Thank you very much, Mr. George.
Wonderful. Thank you very much. And on behalf of LMSK, allow me to thank everyone, our presenter and all the medical laboratory practitioners who have managed to attend and participate in this exciting webinar. And to this far, since we are running against time and time has gone ahead of us, allow me to bring this session to a close. Thank you very much, and I wish everyone a wonderful evening ahead. Thank you, and may God bless you.
Thank you.